right, it looks like it's about time to get started. So thank you so much for being here today. I'm Melinda Pettigrew. I'm the new dean at the School of Public Health, and I'm here to welcome you to the 2024 Health Disparities Roundtable. And I really want to thank you for coming here, both in person and online. The Roundtable is one of the most enduring events that the School of Public Health offers. Health equity is absolutely core to our mission and values, and so I can't state strongly enough how important this work is. The Health Equity Work Group was founded in the spring of 2005 with 4 goals: conducting, promoting, and providing greater visibility of health equity research, strengthening collaborative efforts, creating lasting partnerships with our community-based organizations, and ensuring that the School of Public Health students and faculty work effectively in a diverse society. The Health Disparities Roundtable aims to amplify health equity work by inviting organizations to address the most pressing issues in public health. We are here today to identify and discuss effective and sustainable policies, practices, and programs to advance health equity. To do this, we need to recognize and understand the unique challenges facing the public health workforce, the social determinants of health that disproportionately impact marginalized populations. These include racial and ethnic groups, low-income populations, differently abled populations, LGBTQ populations, and rural communities. These social determinants also impact our public health workforce. A strong, vibrant, and dynamic public health workforce is absolutely critical to advancing health equity. In order to improve the lives of the communities that we serve, it is important for us to look inward and think critically about how we train and prepare the next generation of public health leaders. Before we continue, it is also important to acknowledge that the School of Public Health at the University of Minnesota is built within the traditional homelands of the Dakota people. It is important to recognize the peoples on whose land we live, learn, and work as we seek to improve and strengthen our relations with our tribal partners. We also acknowledge that words are not enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. Next, I want to thank everyone who made this year's roundtable possible. This includes the School of Public Health's Health Equity Work Group, the University of Minnesota's Public Health Dean's Office, the Office of Diversity, Equity, and Inclusion, the Center for Anti-Racism Research and for Health Equity, the Center for Leadership Education and Maternal and Child Public Health, and the Medical Schools Program and Health Disparities Research. And we must also acknowledge and thank Joe and Sue Weisenberger. Finally, I really would like to thank the Community Engagement Committee members for all of your hard work in planning today's events. And I'm looking forward to this. And now I'd like to turn it over.
Hi, everyone. Welcome. My name's Jeanette Dill, and I'm an associate professor in health policy and management, and I'm thrilled to be here for today's roundtable, and I'm honored to be able to introduce our guests today. So our keynote speaker is Dr. Bianca Frogner. Dr. Bianca Frogner is a health economist and a professor in the Department of Family Medicine and the School of Medicine at the University of Washington. She's the director of the UW for Health Workforce Studies, CHOOSE, and the director of Primary Care Innovation Lab, both housed in the Department of Family Medicine. She's an adjunct professor in the Department of Health Systems and Population Health in the School of Public Health. She currently serves on the Washington State Healthcare Cost Transparency Board. She has been called by the National Academies of Science, Engineering, and Medicine, including to serve on the Consensus Study Committee on Educating Health Professionals to address the social determinants of health. She has given state and federal testimony to inform workforce policies. Dr. Frogner has produced over 150 publications, including peer-reviewed articles, book chapters, and reports. She has received awards recognizing her scholarship as well as her mentorship. And she has delivered over 250 scholarly presentations and has appeared in media outlets including CNN, NPR, The Wall Street Journal, Washington Post, and Politico. So welcome, Bianca. Let's see, you know, I'm gonna do all of them. We're just gonna plow through, and then I'll have you come up, okay. Our second speaker is going to be Commissioner Brooke Cunningham. Commissioner Cunningham was appointed in January 2023 as Commissioner for the Minnesota Department of Health. Dr. Cunningham is responsible for directing the work of the Minnesota Department of Health. MDH is the state's lead public health agency responsible for protecting, maintaining, and improving the health of all Minnesotans. Dr. Cunningham is a general internist, a sociologist, and an assistant professor in the Department of Family Medicine and Community Health at the University of Minnesota. Prior to joining MDH, her research focused on developing strategies to reduce racial disparities in health, including the adverse impacts of exposure to racism. She also co-directed the University of Minnesota Medical School's Diversity, Equity, and Inclusion thread in medical education. In 2021, she was selected as one of 4 inaugural recipients of the University of Minnesota's Justice, Equity, Diversity, and Inclusion, or JEDI, Award. Cunningham is a primary care provider at the Community University Healthcare Clinic, a federally qualified health clinic in Minneapolis that serves a diverse patient population. And then last, we have Dr. J.P. Leiter. Dr. J.P. Leiter is an associate professor at the University of Minnesota in the School of Public Health. He was the founding director of the SPH Center for Public Health Systems. In his role as senior fellow within the Division of Health Policy and Management, he's actually an associate professor. Dr. Leiter works closely with the division's Master of Public Health, PHAP, and EPHAP programs. His responsibilities encompass mentoring students, designing curricula and programming, and teaching courses on health policy, budgeting, and financial management. As the director of CPHS, Dr. Leiter collaborates with faculty, staff, and students across SPH to provide support for public health practice and to conduct research and evaluation in public health systems. He maintains a robust research agenda with more than 140 publications in public health workforce systems and workforce development. The center works with practice partners, foundations, national public health organizations, and researchers to establish a sustainable public health workforce addressing identified U.S. public health needs. All right, so welcome to all of our speakers, and we're all looking forward to what you have to share today.
All right, good morning. Hope everyone's doing okay today. All right, let's see how I can get my presentation up. Well, thank you so much for having me here today. It's so wonderful to come out to Minnesota and visit with friends and colleagues, make some new ones, and to see all of you here today. And for those of you online, thank you for being online here. And thank you to Jeanette for my introduction. It's always so embarrassing where you're like, oh, that's so long. But anyways, it's such a pleasure to be here. So before I begin, I figured I'd tell you just a little bit about myself and where I come from and kind of why I found myself where I am today. I'm an only child. I'm a daughter of parents who are aging. I mean, we're all aging, but my parents are certainly getting up there in age. And the funny part is they follow me around the country. I joke, but really they do follow me around the country. And and I feel very fortunate for that, especially as they're getting older, because I'm recognizing that I'm probably going to be their primary caregiver as time goes on. And what I start realizing is that, oh, I'm going to be their support system in a fairly complex and fragmented health system. And this is what has really motivated me, is to try to understand how can we fix this health system, not only just for my parents, but for all of us. And then I'm realizing, oh, well, I have a cat and a dog, and my husband, and no other family really here in the country, so perhaps I'm also trying to fix it for myself, so selfish reasons here. But no, but I realize how many people fall in the same kind of situation as myself and my parents, where we're all trying to figure out how to navigate this complex health system. And in a lot of ways, we're all trying to figure out how can we age at home and live a productive life long term, and that's what we all really want. And so I come from this also as a wary consumer of healthcare, not just someone who studies the healthcare system. And I'm really committed to trying to figure out how to improve the lives of people who work in the healthcare system and try to improve all of our health. I'm fortunate to work with a fantastic group of folks at the Center for Health Workforce Studies, or CHOOSE for short, where we have been housed for over 25 years. I have been there for about 10 years myself, and we conduct health workforce research on a broad spectrum of healthcare workers, really with an eye on trying to figure out how to inform policymakers. And with the support of federal grants and contracts and other state work, we try to really think about issues of career pathways and program development. But we are not the only ones in the country to do this kind of work. Even here at University of Minnesota, there's a new consortium for workforce research and public health led by JP Leiter and Jeanette Dill. And it's exciting to see a new center focused on the public health workforce come to fruition with the support of the Health Resources and Services Administration. And I highly recommend, if you want to learn more about what centers are doing around the country on the health workforce research field, I highly recommend the Health Workforce Technical Assistance Center as a wonderful place to start. So I do want to just encourage people to learn about what other centers are doing around the country, and to also say that people are doing research on the health workforce in a number of other places other than federally funded centers, and I do want to encourage you all to learn more about that. So I know I'm here today to talk about the public health workforce, and my colleagues and I at the Center for Health Workforce Studies did write a piece in Milbank Quarterly, who celebrated their centennial issue last year, where they dedicated the entire issue to population health issues. So if you want to learn more about population health issues, I certainly recommend starting with that full issue, because there's a number of wonderful pieces there. And in our own investigation about the population health workforce, I think we really came to realize how many people are really having to be involved and activated to be involved in improving population health. And population health really is about thinking about many different kinds of communities in our population and thinking about the needs of the population. So not just thinking about the people who show up to the healthcare system, the medical system, but the people living in their homes, living their everyday lives, and thinking about how to keep them out of the health system as much as we can and keep them healthy again in their homes, in their neighborhoods, and in their communities. And so you do need the medical workforce, but you also need social services workforce, but you also need folks who are doing urban planning, people who are who are educators. We need everybody really engaged in population health. So as a result, we can easily just say there's millions of people who are really going to be involved in population health. It's not just one group of people who this falls on the shoulders of. And we need to figure out how to get the competencies across multiple groups of people. But that means that it's also complex to figure out how to elevate them. Now, I'm going to be talking a lot about the medical systems workforce, in part because of the challenging nature of really defining the entire population health workforce. I know JP Leiter will talk a lot more about the public health workforce, who is a critical component of the population health workforce. Other critical workers include folks like community health workers and doulas, who share a lot of the characteristics of the groups of healthcare workers I'm going to focus on today. Oh, there's no labels. Interesting. Okay, well, I will have you play a game and guess what numbers associate with what groups of people up there. Fascinating. Okay, I've never had that happen before. All right, so one of the things that we do pretty well is counting the healthcare system's workforce. What we don't do so well is counting the population health workforce. And partly that's because there are occupation and industry codes, and we can get really wonky on this, but there are good coding systems that kind of characterize and categorize different kinds of workers. And it's important that we have those systems so that then we can find them in other kinds of national surveys that are taking place. And oftentimes we rely on the Bureau of Labor Statistics or census data to help us identify who works in our economy, in what kind of jobs, in what kind of industries, and then from there understand some of their demographic characteristics, their life course, things like that. And so in this slide, I was trying to show data from the Bureau of Labor Statistics, from the Occupational Employment and Wage Statistics, to show you that there are about 17 million people who work in healthcare who are about evenly divided across three major sectors. That 35% represents hospitals. The green boxes, and unfortunately I color-coded, and I apologize to anyone who might be colorblind and may not see these colors so well either, is that the green boxes represent people in the ambulatory care sector. So that's your outpatient care centers, your physician offices, et cetera. The other red boxes there represent the long-term care sector, and that includes skilled nursing facilities, residential care facilities, and home health. And I think what's important about this is just to say that there are many places in which healthcare is delivered. And who's not really included in this 17 million and certainly play important roles are people who work in community pharmacies. So in your retail retail settings like Walgreens, I don't know what your local stores are, CVS, things like that. And that's probably another about 700,000 people who work in those settings. There's about 100 or so thousand people who work in public health agencies at the state, local, or federal level, and JP can probably correct me on what the exact number is. So maybe closer to 140 is what I found anyways. You're at 200,000. Oh, okay, my data might be out of date. Well, thank you for that. And then there's also community-based services that are not included in here. So just saying 17 million is kind of like the minimum number of people who really work in the healthcare system. Okay, getting a little bit better here. So out of that 17 million people, yeah, that box does not quite highlight what I wanted it to highlight. So out of the 17 million people, what that box is supposed to highlight are the 3.6% of people who are physicians. And I note this mostly because a lot of the discussions around the health workforce tends to center around physicians as well as nurses. And nurses are about 15% of that pie and are the single largest occupational group in the healthcare system. So rightfully so, they deserve a lot of attention as a fairly big group. However, it's important to note in the population health workforce, there's an important segment of folks, I'm sorry, these boxes just don't really align, that include about your social workers and counselors, people who are working on that behavioral health side, and they're about 3% when you combine them together with community health workers. And just putting that on par with the physician workforce being about 3.6%, I think it's important to note that they play just as large of a number, at least count-wise, role in the healthcare workforce. And where I'm going to spend a lot of my time today is talking about the healthcare support occupations, which are people who hold a title like an aide or an assistant title. So these are your nursing assistants, home health aides, your medical assistants, your pharmacy aides. And I think these are very important people for a number of reasons, which I'll kind of articulate as time goes on here. But they're particularly important because they're oftentimes the front face for many people coming into clinics, coming into any healthcare setting. I mean, I don't know how many of you have had conversations with your family members where they're like, oh, I saw a nurse when I first came into my doctor's office. And then you realize, I don't think you saw a nurse. I think you saw a medical assistant who took your blood pressure, took your weight, took your temperature. And a lot of times they kind of get mixed up with who is really the nurse in the room. So you just realize what an important front-facing role they play and how recognizable they are to many people as they come in. So I think this is an important group for us to consider. In part because, let's see if my box is getting any better here, and it did, okay. So the healthcare support occupational group, so all those people in those aides and assistant roles, they are considered to be one of the fastest growing job categories according to the Bureau of Labor Statistics over the next 10 years, next to computer and mathematical occupations. And you think about how much attention computer and mathematical jobs gets in the media. And how about the healthcare support occupations? I mean, how many of you assumed that this was the category that was growing fast? Probably not many, but they certainly deserve attention. Now, healthcare generally has always been a very good job engine for our economy, so we can find a lot of people finding their way into healthcare jobs, and I'll just note as part of that is that those kind of higher level education jobs of healthcare practitioners and technical occupations, which include your physicians and nurses, they are among the top 10, as well as community and social services, who are very much part of the population health workforce. So these are places where there are going to be jobs into the future. I'm going to take a slight pivot here and talk about diversity. So we need not just the count of people to be present to do the work, but we need a group of people in these jobs who also reflect the community. And the thought is that by having a diverse workforce, that this might get people more engaged with their health care because they feel recognized, they feel understood, and that in turn that this might help improve health disparities and ultimately help us achieve health equity. And a lot of times I hear statements that say, well, the health workforce is not very diverse. And it's not very diverse, but in certain kinds of jobs. And it's mostly the high-educated, high-paid jobs where we don't have diversity. Where we do have quite a lot of diversity are in those healthcare support jobs that are growing very quickly. And it is actually very racially and ethnically diverse specifically. It's not very gender diverse. It's actually fairly female-dominated. So this is where I'm going to talk a little bit more and concentrate my next couple of slides. My colleague Jeanette here and I have done some work looking at various characteristics of the health workforce and looking at how some of that has been changing over time. And this is just a slide that comes from a study that where we looked at some gender gaps. And I think a couple key takeaways from here is that, when you look at the health workforce in general, it is a very big employer of women. And that's important, and it's about 75% women when you look at it in aggregate. But when you look at the different job categories, it's the jobs that require a high school degree or less, so a lot of your healthcare support occupations, where we have up to 80 to 90% of women in these jobs. Now, I will say that, unfortunately, at this point in time, most public data sets only identify sex and gender as a binary of female, male, women, men. So I'm sorry that, I'm not able to provide a lot of detail on other categories of gender and sexual identities. So in these slides, you'll see me talking about in a more binary form. Where we have seen some improvement in women representation is in our higher educated jobs. However, we're still seeing only about 50% or so of those jobs being filled by women. When another study actually by Jeanette here is that what we're, and with a colleague, Ming-Yun Duffy, is a study in health affairs where they broke down even further to look at the distribution of the health workforce by different sectors and looking at by race and ethnicity. And I think what's particularly notable is where we see particularly a lot more Black women in particular, which is in our long-term care jobs, again, in aid and assistant jobs. So there's a long history of kind of historic legacy of slavery that's really playing out here, and like an ongoing challenge around racism that's kind of finding its way into healthcare, or basically has created the healthcare system in which we have, where we are finding women who are of color, particularly Black women, in these ongoing caring roles that are very low-paying jobs. Where we don't have as much diversity are women who are or people of Latino descent, but particularly women even of Latino descent. And my colleagues and I at George Washington University did some more detailed work to better unpack the Latino community, since they are certainly not a monolith. And what we really recognize is the high percentage of Mexican Americans in particular in many of these jobs, but where you find them again are mostly in the aid and assistant roles. So you probably are starting to pick up on a theme that our aid and assistant jobs, our healthcare support occupations, are very diverse. However, there are also challenges that come along with that. Jeanette and I also did a study looking at turnover during the pandemic and then some periods after as the pandemic is going on. And I think a key takeaway is that turnover rates during the pandemic, but even before the pandemic and ongoing as the pandemic kind of unfolds, our workers of color, our racialized communities, are the ones who have been seeing high levels of turnover ongoing. And in addition to that, when you look at the different occupational groups and where turnover is highest, it is the aides and assistants who have had high levels of turnover during the pandemic, but also before the pandemic. So something is going on here, and we need to better understand why these things are happening, because this is certainly, there's something hand in hand about the jobs that are experiencing these high levels of turnover, combined with the fact that we have workers of color, particularly seeing high levels of turnover. Now, slightly good news is that we are seeing workers of color coming into the healthcare system in this kind of more post-pandemic period. It's always hard to know what's exactly the right word, since while the emergency has technically ended, we are still very much still living with COVID in our society. But we are seeing that people are coming into people of color, racialized communities are coming into hospitals and offices and outpatient centers a little bit more often than they are coming back into long-term care settings. And that's encouraging, because these tend to be more higher paid occupations. So that's a slight nice silver lining, and the fact that maybe we're not losing as much diversity, which was a concern we were having. All right, so what does that mean? There's a lot of underlying kind of structural challenges that we have as a society that is contributing to the high levels of turnover that we're seeing, and particularly among our racialized communities. But there are things that we can do to try to improve this. And we do really need to focus on targeting, I think, our healthcare support workers, because they are, again, the front-facing people who are often interfacing with our patients, and really the ones who have an opportunity to be educated and promoted and been given the competencies to address population health. But in order to address population health, we need to address their own social determinants, really, of their own health and as well as their life. And among the things are addressing wages. When you look at the orange bars here, healthcare support workers are making oftentimes below $20 an hour, which is what that red line was supposed to indicate, and they're oftentimes the lowest paid group among all those categories of workers. When it comes to insurance, unfortunately, well, I'll start with the good news. Healthcare generally does better in terms of uninsurance rates relative to the rest of the population, but when you look at the long-term care sector, and again, that's where a lot of the support occupational roles are, that's again where a lot of our Black women work, we have higher rates of uninsurance in that category, including also a lot of reliance on Medicaid. And you know, Medicaid is really a lifeline in terms of a source of insurance for many of our workers. And the uninsurance rate, you know, there are ways we can improve this. One is that in Washington State, we have a new bill in place that has child care workers potentially having to pay 0 premiums to get health insurance. And why can't we do the same for all healthcare workers in a similar situation? So we know that there are potential solutions here. And also, really, should we have healthcare workers who work in healthcare without health insurance? I think that's just a question we should ask ourselves. Healthcare workers, particularly in the support roles, rely a lot on public transportation, where we see a lot of our home health aides and nursing assistants relying more on public transportation than any other segments of the healthcare workforce, as well as more than even what we see nationally. So we can do more to also subsidize public transportation. Earlier today, I was talking about how I used to be the lead of a van pool, and while that's one kind of solution, there's certainly options that our counties can do to subsidize public transportation or encourage ways to find more even climate-friendly, you know, solutions to get people to work. A lot of hospitals, in particular, have noted the challenge of affordable housing, and hospitals have taken it into their own hands oftentimes to actually work with developers to create affordable housing that's specifically for their workers. A lot of this has been happening in more towns that are vacation towns, you know, your ski getaways, your, you know, island vacations, because those are places with really high costs of living, plus the fact that lots of those neighborhoods have a lot of Airbnbs, and so there's not available rental units available to workers, but yet those communities certainly do still need workers. And they're oftentimes places where people retire, so you have an aging community where you also need long-term care. And without affordable housing, when people are making less than $20 an hour, how can they possibly afford housing? And adding to that, given that this is a very female-dominated field, childcare is very critical. And if this is just a slide that I found about, I guess it was using this national database of childcare prices, and it shows you what some of the median annual prices of childcare. And I'll just note particularly the red dots, which represent large counties, so mostly urbanized counties, that sometimes the childcare cost can go up to $15,000 a year. And think about, again, someone who makes $20 an hour, if they're lucky, that's $40,000 a year before taxes. And then they have to pay $15,000 of that to childcare alone. And that's just for one child. So that's something we have to think about, childcare, and figure out how to prioritize that. Lastly, the other thing we need to do is figure out how to invest in career development. We do need people to be in these jobs. We do not always want to train people out of their jobs. We do need to figure out how to value people in these jobs. However, part of it is also figuring out how to invest in people's careers so they feel like they have investment and buy-in from their employer in their life. So in that, we do need to think about how we can provide people more skills while also being on the job. I too often hear people say, well, medical assistants, the best ones become registered nurses one day. And I'm like, well, that's great, but you know, at this point in time, to get a high-paying nursing job, you have to get a bachelor's degree. And that's a 4-year degree for someone who started off with a high school degree. And that's not easy for a lot of people where they may not have any family members who have ever been to college. On top of that, the cost of education is incredibly high. And many of these people also have families, and oftentimes are a primary breadwinner. So to walk away from their job to go back to school is a very difficult endeavor. So there are ways that we can address this, among which is doing federal apprenticeship programs. And there are models for this around the country. But we don't have to jump immediately from medical assistant to registered nurse. There are programs that are starting to show up, even in the state of Washington, where we have a nursing assistant pathway to a licensed practical nurse position as an apprenticeship. And this is being funded through our state's workforce board in conjunction with state funding. So there are opportunities to leverage state funds to help people earn while they learn and move into higher level and higher paid jobs. So all this to say, population health involves many, many people, both in the healthcare and non-healthcare arena, but it's difficult to really count and track activities, especially if we don't have good ways to identify, code them. We really need better data on our population health workers, such as doulas and community health workers, our public health workers, and other people who are building bridges with our community members. And increasingly, we're getting better data on community health workers because they finally actually have their own standard occupational code, and that very minor and wonky thing really matters in terms of our ability to identify workers, count them, and say, hey, they really are playing a strong presence here. We have not yet to see a code for doulas, but maybe in this next round we might see that. Healthcare is very diverse. I hope you do walk away realizing that, but when we talk about diversity, where we're talking about diversity is in those low-paid jobs, too often filled by women and women of color. And to prevent building a population health system on the backs of marginalized populations, we really need to invest in our workers, and hopefully in the many ways that I showed, because there are policy solutions out there. We just need some political will and some employer action to make that possible. Thank you so much. I probably shouldn't have exited. Sorry, I exited out of here and I don't know how to get it back. I don't know if someone else can help me. All right, I'll let someone help.
Good morning, everyone. My name is Brooke Cunningham. I am the Commissioner of Health at the Minnesota Department of Health. Bianca, thank you so much for your comments. You know, I get to start up here by celebrating some of the things that we've been doing at the Department of Health, and one of the wins for us in the past legislative session was our Equitable Care Task Force. But one thing that I talk about, because people are like, well, what can we do to advance equity? Well, healthcare provider organizations can start at home. They can look at their staff. They can look at occupational stratification within their staff. They can think about the barriers for their own staff to achieve their optimal health outcomes, and they can look at who among staff gets a living wage, has health insurance, and has pathways to promotion right there at home in their organization. So I really appreciate your presentation and lifting that up. And so today, my approach to the topic is really to begin to talk about what we're doing at the Minnesota Department of Health, really to talk about how we are thinking about our work to advance health equity and the role of state governmental public employees in these spaces. And so we were able to go deeper with advancing health equity really through a lot of the COVID funding that we saw, right? Part of the emergency response was that we had to reach harder to reach populations quickly, and we had to develop new strategies and partner in new ways, and we had to do it quickly, but we actually had the funding to do it. And there were a number of initiatives coming out of the federal government, and the one thing, of course, at a state public health agency or even a local public health agency, a lot of our funding flows from the federal government. And so with the COVID monies, there was a CDC Health Equity Grant that allowed us to invest in new spaces, including building out an Office of American Indian Health and regional health equity networks. And our regional health equity networks are sort of learning collaboratives that we host around the state where individuals, leaders, and organizations can come together and share with each other their lessons and their struggles about advancing health equity in their local spaces. And so that COVID money was critically important, but there were other COVID funds that allowed us, again, to reach harder to reach communities. And so part of what we've had to do is we've come out of the pandemic, and fortunately in Minnesota we had that historic legislative year last year where we had a 17 to 18 plus $1 billion surplus. So me moving into the role as commissioner was really to argue and articulate really for the importance of public health, which never really takes up much of our overall health budget when we talk about health care and public health. Public health always, whether you look at national budgets or you look at state budgets, it's around 3 to 5% pre-pandemic in terms of how it's funded. But we did get new money, so we were able to go deeper in new strategies, including working with community groups in different ways. Two that I like to highlight were our COVID community coordinators, and those were community-based organizations who had the trust and knew the strategies for their local communities. And so what we've been able to do with additional fundings is to keep those folks on post-pandemic. I'll touch on this a little bit, but we have a whole lot of discussion about who are the players in the public health or population health space. We talk about healthcare, we talk about governmental public health, we talk about academics, right? But we also have to talk about community-based organizations and the nonprofit sector and who's working in those spaces as part of our public health workforce. And we needed those folk for the pandemic response. The other thing we needed was more diverse media strategies, right? Media has changed, and to the extent that I can pull, the new dean's coattails, what I will always say is, like, we need communication strategies for the 21st century, right? Folks are using social media. I'm not on anything. I'm not the right person to do it. But what we know is there is a push of content out to people where they are. There are platforms, there are TikTok. And one thing that we're doing with some of our COVID monies as we put forth a proposal, as those monies have gotten extended through 2026, is for us to have TikTok influencers. And I mean the young people, right, in the high school who actually reach a number of folk. How can they help us, again, as we think more expansively about how we reach folk in public health? And as we think particularly about substance use and a number of our ongoing challenges, as we think about vaping, as we think about sexual health risks, as we think about even developing the opportunities for healthy living conditions, how can we engage our young people and their creativity and their access to others that we don't have access to? And so, again, just really thinking about how we can leverage these dollars to reach the public in new ways to advance equity. Part of our communication strategy that we saw in COVID, which was again grant funded, which you all know the risk of grant funding, was moving from what has largely been largely English, certainly English first, not always English only, but certainly English first materials and language. You can't do that in a pandemic, right? Everybody needs information and they need it now. And so we were able to get some core team members on staff. Clearly we live in Minnesota. There's lots of languages spoken in Minnesota, but clearly Hmong, Spanish, Somali are core languages that we needed to get materials out quickly, and we can't lose that. So part of, again, my work as commissioner and the team's work is to say, okay, we're about to lose this COVID money. How do we keep this? Not only just translation, but it's also the content, the cultural content that is important in the message. And so again, part of our work and what we did have a success with last year in the budget session was to keep that team in place. with the investments from the federal government into public health infrastructure. The other thing that, you know, we are tasked at the agency, and many of you all may be similarly tasked, is when you work in organizations that can be heavily siloed. You can have the equity team, right? They mentioned in my introduction, right, that I led this DEI thread, I co-directed it at the med school, and what often we find that happens as organizations is no matter how much we say equity is everybody's job, it ends up being like 2 people's jobs over here, right? And so part of what we did with this money was saying, with this workforce money that came to us, was saying we're gonna invest in health equity strategists. And this was a conversation that developed when I was assistant commissioner. And there was a push because I said, these are health equity strategists to think about the underlying logic and operations around our public health work. These are not, as much as community engagement is critically important, community engagement, that's often, again, when we talk about, you know, Black and brown people in the organizations, you're gonna hire Black and brown folk to go talk to more Black and brown folk, but you don't put them at the core of, like, what is our strategy around our public health programming? And so part of the messaging from our Health Equity Bureau was, these are strategists. These are to think with your leadership team about our core work. And so I'm really proud to see that to have grown. The other thing that I will lift up a little bit in our talk is new spaces that we had to go in as part of COVID, right? We know mass incarceration is a public health problem. We know it is a problem with infectious disease. We know, you know, jails and prisons are congregate settings, right? And so we had to develop teams, and then the challenge for me now, right, is to maintain those teams. You all are getting a theme here, to maintain those teams that were critically important, right, in our correctional system to protect folks' health. And so again, with our ongoing monies, right now, we can maintain the team, but the challenge for public health work generally, but particularly in the equity space, and I'll end on one particular challenge in the equity space, is to maintain these teams of folk. And clearly incarceration, right, it's not just a risk for the individual, it's risk for their families in terms of the particularly economic and social disruptions and community disruptions that, you know, that incarceration causes. It's also a community health risk, right, in terms of people moving in and out of congregate settings, and particularly jails, back into communities. And so when I think about equity and when I think about health risk, we have to also think about that particular space. And again, we've been able to do it, and part of the challenge for me is how we continue to do it. And as we think about opportunities, and there are some opportunities that people have looked at, to Bianca's point, in terms of how do you move folk from one occupation to the next occupation to the next occupation. But one thing, again, with these ELC dollars, and this is where I think it's a lesson for us. We can get really locked into thinking about traditional ways of working. Jeanette is giving me the 5 minutes, and I'm only on page like 2, but okay. So, so I will just say, but one of the things that that we have done with COVID dollars, and I encourage everybody, particularly who has a grant opportunity to do, even though you have to meet the deliverables of the funders, to get really creative with how you use your dollars. And part of what we've, again, done with some COVID dollars is think about what is our immersion experience for young people. Because at the Department of Health, we have a lot of master's students from the right? From School of Public Health. We have a lot of master's students. We love y'all, you know, particularly in infectious disease and maternal and child health. But you know what we also need? We need the 8th graders, right, who don't know nothing, who have heard about the doctor and have heard about the nurse, but haven't heard about public health. And while there's a healthcare, you know, workforce shortage in certain spaces, there is certainly a public health workforce shortage. And our young people need to know about the work that we do in public health, and particularly given the science and the STEM content of that work, it's good for them to have an exposure experience in public health as an entry point to thinking about the whole sort of STEM space. I have so many things to talk about, but I have got to skip ahead. I'm gonna skip ahead. Let me see where I want to land. Let me move forward to some spaces, because I've shared some strategies and really some of the good stuff that we're doing, but clearly we have a lot of opportunities still at the department, right? We need to go much deeper in terms of thinking about how we address disparities associated with disability, associated with sexual orientation, gender identity, geographic health disparities, rural health inequities, particularly poverty, isolation, mental health, and suicide in greater Minnesota, and but also geographic distribution of resources and protective factors right here in the metro. I will say that when we think about preparing the public health workforce, I do think that leadership is critically important, right? It was Commissioner Malcolm who created the Health Equity Bureau, and hence, I came into the department. It was Commissioner Malcolm who signed off on, yeah, let's put these health equity strategists into the work. So she was highly supportive of our Health Equity Bureau, and to have leaders in the rooms where decisions are made who have equity at their forefront and who can influence not only what we do at the state level, not only decisions in those backdoor rooms, but also who can cultivate what it's like to work in the place, right? So that equity, so that people have not only a sense that equity is valued in a real concrete, tangible, not just talk way, but also valued in terms of their belonging in the organization. What we have seen, so that started a ball rolling, and I do give props to Commissioner Malcolm, and from there we have grown the Health Equity Bureau tremendously over her tenure going out and my tenure coming in. In 2020, our Center for Health Equity had 12 staff. There are now 50 staff in the Center for Health Equity, and the Center for Health Equity is only one program or unit within the Health Equity Bureau, right? But that also takes commitment from leadership, and we also need commitment from leadership in the state, both bipartisan policy maker commitment, but also across the state agencies. And so, of course, I'm going to lift up what we know is important for public health, which are things like things that we got done in the legislative session: the child tax credit, paid sick leave, projecting reproductive health and gender-affirming care, investing in early childhood programs, family home visiting, child care, right? And thinking about educational disparities, because if we continue to live in a state with the gaps in educational outcomes, again, for Black and brown children, we are never going to close these equity gaps. So when we think about our public health, population health approach, it is literally all of us. So like the Universal Meals Program is fantastic, again, for addressing food insecurity, and yet we still have the spaces, and again, speaking to this audience, there are spaces where I need, and when I say I need, worker, I'm not gonna be at, the department, we come through as commissioners, but I think public health needs, so I won't say me, we've been prohibited from doing gun violence, right? Now we can, let's do it. Let's do gun violence, firearm injury policy around that. Let's do stuff around mass incarceration. Let's do stuff around climate change, right? Let's do the work in substance use that we need. And let's do the work in maternal morbidity and mortality. And I lift these areas up because some of them are new content areas, and we need public health science and practice for these areas. Public health students need to be trained in these spaces, need to be trained in communications, because this circles back over and over again about communication strategy. And if you all look out there, and I'll just fast forward to this, I was gonna make one comment about data, which I will make, which is we need, I don't want to call it emancipatory data, but we need to be able to look at our public health data with a critical lens, to look at our methods, to look at our data collection, who's in and out, to look at our analytics, to look at our interpretation. And so we need to cultivate those epidemiologists, those both quantitative and qualitative, analysts who can take that critical equity lens to our data to really advance equity. And I guess the last thing that I wanted to say as I was talking on communication was to say, yes, there are so many fantastic things happening, but 2024 is a bit of a battle, right? I would be remiss if I don't lift up a real challenge that there are concerted, funded efforts to roll back progress on diversity, equity, inclusion, and belonging. Folks are feeling threatened, and it is showing up. You all see it. I see some of y'all nodding. This is real, right? This is real. We've got to be ready for that too, because social justice and fairness are at the core of our public health value set, core to our mission as public health professionals, core to protecting, maintaining, and improving the health of Minnesotans and the health of Americans across the nation. And so part of what I leave with you as we think about preparing folk to advance equity is just the question, are we ready to fight for the soul of public health? Thank you.
Nope. All right, hey everybody. JP Leiter here. I'm so pleased to be able to present. I am anticipating also, like Bianca, some issues with formatting. I'm going to apologize ahead of time, but I see it coming from a mile away. I'm the director of the Center for Public Health Systems here on behalf of a team. And as Bianca was kind enough to point out, we are also really pleased to be the national home of the Public Health Workforce Research Center funded by HRSA and CDC. There are a number of these funded by HRSA, and just a couple of years ago, for the first time ever, there's one for public health now. And we're part of a national consortium of a number of schools, and we get to do projects every year of interest and import to public health. One of the other things that I want to say up front, just to kind of set the table, is that we're really fortunate to be able to have this roundtable, to have this working group, and to be in a state where we can talk about these issues. That's rare, it's uncommon, and while I'm going to be talking about something that's national in scope and scale, it affects all of us in this state as well. So let's just kind of get into this issue. I'm going to be talking today about public health workforce, but I'm going to do that by starting with and before COVID-19. So just really briefly, does anybody remember a couple hundred years ago, like July 2020? Yeah, for me, it was the first time that I can remember professionally when I would regularly get media calls where people asked, so what's the deal with the public health workforce? What do they do? Why aren't there enough public health workers? How did this come to be? Why wouldn't we have enough public health protections prior to this national pandemic? And there were a series of articles written by national media, Kaiser Family Foundation, Washington Post, a number of these entities just kept hitting this note. It's like, why would you be funding firefighters only when the houses are on fire, right? That's the idea. It's a pretty reasonable question. And the truth of the matter was that the public health workforce has been cut for decades. And unlike education or public safety that had been cut during the Great Recession, 2008 through 2013, when that recovery began in the public sector, it never really happened for public health. So coming into the pandemic, we had lost 15 to 20% of the workforce, whether you're looking state or local, 40,000 folks or so. It was exacerbated by baby boomers retiring. The silver tsunami, they called it. So that's where we were coming into COVID. And that leads right into the question of what can we learn from our public health workforce surveillance data. Quite a bit that we weren't able to know before. The data I'm going to show you in the next few slides come from this National Public Health Workforce Interest and Needs Survey. Just for those playing at home, about 45,000 people responded to this survey. And I'm going to show you a few slides kind of in quick succession, not for you to look super closely, especially for those at the back of the room, but I'll show you by setting, race, and ethnicity for those under the age of 35. And again, I think we're going to get some strange layouts here. So for setting, we've got states, Minnesota Department of Health, let's say big cities, Minneapolis, other locals, and then national total. You can see that 20 to 30% of our workforce is still thinking about leaving in the midst of COVID, even after all the folks have left. And this isn't for reasons like retirement. This is just thinking about quitting separate from retirement. If you were to add retirement in, that'd be about 40 to 45% of our workforce thinking about leaving or retiring. This is just leaving. So you can see, regardless of setting, you're a little bit over 20%. Now, if you were to look by race or ethnicity, I'll say very briefly, the all other staff group is grouped together because of size considerations. The largest group in there is Asian, but based on the size of the workforce, that's why the groups are together. Race, ethnicity, again, not too much of a difference. But when you go by, again, 20, 30%, but by age for those under 35 or 35 and under, it's just much, much higher. So where it was 20 to 30% before, now you're at about 40%. Of course, nobody's thinking about retiring, unless you're very lucky, I suppose. It's just a lot more. So for those 35 and under, in the midst of COVID, you had an enormous amount of people leaving, or who have left. But even among those who are still there, you have a huge percentage, not too different by race or ethnicity, who still are thinking about going. And so the question is, why? And that's kind of the crux of what we're going to talk about in the next just couple of minutes. One of the reasons may be that the opportunities for advancement, the kinds of jobs, are going to be very different for young folks, and perhaps there's some differences associated with race and ethnicity or other kinds of backgrounds, structural differences that might be kind of problematic. The first one is, what's the fundamental kind of job that folks can get access to? Like, is it full-time? Is it permanent? Before COVID, most jobs, the vast, vast majority, were permanent, full-time jobs. They didn't always pay a lot, as you'll see, but at least they weren't part-time jobs. They weren't side gigs, right? You know that they were permanent. Over 95% at state health agencies. Now they are closer to 80%. There's a lot of good reasons for that. We have one-time money, recovery money. Money's going to run out, so you can't hire quite as much permanently. But now what that means is, as folks come in and are looking for new jobs, the vast majority still are permanent, but less so perhaps. And again, for the states, the big cities, locals, it's a little bit more not so permanent for locals, not that different overall by race and ethnicity. I'll just go through it quickly here. But what you see for young people, there are some differences by race and ethnicity. You can see for racialized staff that there is a bit of a difference, but one of the other things is just overall that baseline is much higher for young folks. So one of the things to take away nationally is that for young people who this might be their very first job in public health, they're much more likely to see fewer opportunities for full-time permanent positions, right? So that might not be what they're looking for, or maybe it is, but they'll have to move on to other positions, and so that turnover will be much higher, right? But I think one of the fundamental questions is, why would there be a difference at all between the kind of position by race and ethnicity? And so that's one of the next questions we'll look at. When you look in the public sector literature or the private sector literature about differences in earnings, opportunity, one of the things that is often brought up is, well, there's earning gaps by gender, by race, because of differences in experience and education, right? That's one of the reasons that's often brought up for wage differentials. And with so many people responding to a survey like this, we can look at that. So what you'll see here essentially on the right side are graduate education in yellow and purple. And then to left is green for bachelor's, red associates, and that's mostly nursing associates, clinical associates degrees. Blue is less than college. And you can see there's pretty big differences. For the big cities, the state health agencies, they are much more likely to have graduate level education. And other local health departments, less so. But when we shift and we look by race and ethnicity, you can see that for Black staff and non-Hispanic white staff, that is pretty similar in terms of overall graduate level education. A bit different for bachelor's and less than. For Latin staff, it looks a bit different, and then all other staff maybe more similar to Black staff and white staff. So fairly comparable, at least for graduate education. Where things look extremely comparable is for younger staff, with maybe the exception of Latin staff. And I think where that's really worth remarking on is these are, by volume, the largest number of new hires, right? So not completely so, but as you look at who's getting hired, the questions around salary, positions, why are younger staff leaving, salary differentials become harder to explain, and something that's worth discussing and thinking about. Now again, the educational profile, the exact jobs that are being performed, especially as Bianca talked about early on, a little bit different based on demographic distributions, just overall descriptively, but some question about why. So that's something that we can try and disentangle, right? Instead of just doing it descriptively, we can try and look at salary and then match based on other characteristics. So first, let's describe salary. No surprise, in the big cities, thank you. In the big cities, we've got a bit more earnings compared to other local health departments. And that largely is true for the state health agencies who are also in metropolitan areas. So in the red, green, yellow, that's kind of the upper bands, especially the green and the yellow. And then by race and ethnicity, you still see some difference here. The thing I'll say before moving on is that for white staff especially, there appears to be a much more substantial bar for the 75,000 plus that you see reflected for all other staff. Largely driven by, in all other staff, kind of the Asian subgroup that holds similar positions. When you look at age under 35, sorry about the formatting, there's some substantial differentials that you'll note too between the different racial and ethnic subgroups here. So the question remains, is this just based on where people happen to be located geographically, to positions they hold, or the experience even within these age groups? And what I'll say is, even after doing some more advanced inferential statistics, where we can control for those things, I will say that salary gap, whether you're looking overall or by age, those hold. And the question is why? I think we know the answer, but what we do about it remains. So, there is something structural here. This, this working group, I think, knows the things that we have to do to start to break down those structures. But what I want to do in the last couple minutes is pose to this group, and hopefully we can talk about it later, what it means for young people entering the workforce. So we know that there's a gap both for race and ethnicity. We haven't talked too much about the gender gap, which is smaller in public health but does exist, even though our field is largely comprised of women working in the workforce. And think about what it means for opportunities for advancement. So this is a national question. We know why people leave. Yes, it's about pay, but it's also about satisfaction in their job. People leave their bosses, right? They leave because they're not engaged. And they leave because now burnout and harassment, which was not true 5 years ago, but it's a new world in that way. But we also know why people stay, and I'm really sorry about the size. But what I'll read really quickly, it goes benefits, job stability, flexibility, satisfaction, and then the bars are by age. So for those of you in the back, forgive me. What I want you to take away from it is that we are not a monolith in our field. The idea is people have different senses of what benefits are important by where folks are in their career. And so if you're trying to figure out what's important as a leader, maybe engaging people within your workforce, depending on where you are, or where they are, rather, in their careers makes a lot of sense. And so for young people thinking about entering the workforce, those benefits are incredibly important, differentially, right? And it's important to recognize that. What I'll end with is saying that, yes, we have a structural problem in our field, just like the public sector does. But unlike the public sector, it feels like we are much more willing to engage that conversation. We recognize that to serve our community, we need to be able to reflect it, right, in our demographics, but in our supervisors, managers, and executives as well. Not merely kind of the overall diversity, racially and ethnically and otherwise, in our workforce. And that means that we need to be able to recruit and retain staff that reflects the community too. And I think it means that we don't just pay people more, which sounds odd, because we should pay people more, but that doesn't mean that we can pay people more all around. There are targeted ways I think we can pay people more, but also it's the government. And the government can't just, write all these checks all the time. Though some years it feels like we can. I think that we can work within the constraints of government. We can recognize that there are specific occupations where we are really not competitive and we have to do better. But I think that we can also work within this idea that, yeah, there will be periods of austerity, or yeah, we just don't have unlimited money, but that we have to recognize that there are specific ways that we are just not being fair in how we advance individuals or groups and take specific steps to address that. And that who gets what kind of jobs matters. Certain states have been better about that, I will say. In Minnesota, we're not perfect, but better than most states. And that brings me to the last question, or a couple maybe. How do we hire people fast enough that they actually want to work for us? How do we talk about this in states that are not Minnesota, where you can't even say certain words? And how do you talk to leadership about these issues where they think that pay is the only thing that matters? Because what I will say, having done this work for a while, is that pay matters a lot, right? If somebody wants to quit because they want to go and make a lot more money across the street, you're probably not going to convince them otherwise. But if it's one in a series of issues, you have to be able to tell somebody and convince somebody in leadership somewhere that there's a lot you can do within the context of leading your organization to make somebody want to work with and for you. And around really thorny issues like structural and systematic racism, that can be really hard to talk about. So I think with that, I'm going to leave it there. Jeanette, turn it back to you. We're going up here?
Yeah.
All right.
All right, so this is a roundtable, so we have a lot of time allotted for discussion and for questions, and so I really encourage you in the audience as well as those online to join in this conversation. So I'm gonna ask some questions of our speakers, but I would really love it if you would ask questions because we really want to hear from you. So you can come to the microphone to ask questions. You can see there's microphones at the front of the room, but we also have note cards and pencils if you would like to write down a question, and then you can just hand it to our facilitators in the aisles, and then they will pass along the question. So feel free to interact in any way that feels comfortable. All right, so I'm going to start off with just a small question for our speakers, and then we'll start taking some audience questions. So the first question, no big deal, is what are the biggest health equity challenges facing the public health workforce? And I think I'll just allow each of you to give a short answer. Does anyone want to volunteer to go first? Does anyone just have a quick one off the top of their head?
Oh, it's so hard to pick one. It's like saying, what's your favorite child? Favorite animal? Pets. We talked a lot about pets earlier. I mean, I think one of the things that JP actually mentioned is just the biggest challenge actually we're facing is probably the environment in which we're in politically, that it's really difficult to have the conversation. Because if we can't even have the conversation, almost none of it can move. We can't make any progress. And so there's a lot of, I think, fear starting to come up in our society about having honest and open discussions about structural racism, about talking about inequities, and it's showing up in our government as we see money, disappear for programs. So I think actually one of the challenges is just our current political environment. Now, within health equity, it's hard to say, where do you prioritize issues? Because a lot of times in our research, we oftentimes are focused on variables that you can measure, and then saying, okay, you have a group of people by gender, you have a group of people by race and ethnicity, and then we talk about those groups separately as if they're different groups. But we know the intersectionality matters, and I think this is where what we probably need to do is figure out how to have better research, communicate the real life experiences of what's happening on the ground. So I think one of the challenges around health equity is figuring out how to better articulate the groups of people that really need help the most. And a lot of times, again, in research, we find ourselves talking about interaction terms in a regression model. And I'm a quantitative person, so I'm certainly guilty of this. However, I think just trying to figure out how best to characterize groups of people and say that different groups are struggling with challenges, and there's also shared experiences, and trying to get those two kind of conversations happening at the same time so that we're all working together towards a purpose is a challenge that we're having, which kind of goes to the communication conversations that Brooke mentioned.
So I'd like to build on that and say, from a workforce perspective, working in other states where there's this real political and I will say ideological issue that's come up since the pandemic, there is this downward pressure on workers that want to do more with respect to health equity issues that are not allowed to do so. And so answering the question around what's facing the workforce is people that are wanting to do it, but are either feel like they're unable to do so because they've seen colleagues removed from the job, or have explicitly been told that they cannot for whatever reason. And so working with those folks across the country, they've kind of explicitly told me, right, or have talked nationally or within the privacy or safety of working groups, that's a real challenge they face, trying to do the work as public health workers in those political or ideological environments. I think it's incredibly hard right now.
So I would just agree with my colleagues here. The political environment is real. You all know that. You see the public discourse. You see the loss of civility that has characterized the sort of public discourse, we have gone from a really tough 2020, but that was characterized by some new conversations around, structural racism and inequality, and we have sort of regressed. And now it's not safe. It's like less safe than it was in 2019 for many of us in an equity space where you can not only in certain places not talk about equity, you can't talk about social determinants of health, like we are in ideological sort of wars that manifest themselves across the sectors that are our principal funders, right? So again, 60+% of our budget comes from the feds for the state health department. The other majority, comes from the state. And being able to articulate and sort of advance an equity agenda in a political climate that in many places, less so in Minnesota than other places, right? But that is hostile to an equity agenda is really tough.
Yeah.
All right. We have a lot of questions from online, so I'm gonna just start moving through them in the order that they've appeared. And the first one is for Dr. Frogner. And the question is, where do home and community-based services come into play? They support the healthcare network as well. And I think this person is looking for some clarification about where they're categorized in your analyses around sector. But I think it's also a little bit of a broader a question about what is the importance of home and community-based workers.
Yeah, thank you for that and for asking about that clarification. So home and community-based services are, at least in the way I categorize them, is falling in that long-term care sector, oftentimes because a lot of the supports that population of workers is providing is for people trying to age in the home. But certainly there are people who work in that sector who don't just take care of people who are older. We also have people with intellectual disabilities or other physical disabilities that also rely on those services. And sometimes home health is not just a long-term activity, it's also sometimes a short-term activity, depending on kind of people's more acute needs that can be managed in the home. However, in terms of what their role is, I think about the importance actually that they play in population health in that they are in people's homes. They're there every day. They can see the safety of the environment in which people are living in. They see the kind of food that people eat. They are actually oftentimes responsible for making sure people are fed and bathed and clothed. And so they can actually see front and center the social determinants of health that patients are struggling with on an everyday basis. And so they are critically important as that frontline workforce for the population health field. However, oftentimes they are not very well equipped, I think, with knowing what to do other than providing the limited source of care that they are prescribed or allowed to do. Because some states have some restrictions around the scope of practice of what they can do. A good colleague of mine at UCSF, Joanne Spetz, often talks about how home health aides in California are not allowed to provide eye drops for their patients because that's not within their scope of practice. And every state sets different rules about what different kinds of people can do. So we need to go back and look at why some of these restrictions are in place and how can we really leverage the opportunities that these people have by being in people's homes. And among them is saying what kind of additional education or training can we provide these workers to be even more elevated to address these needs, because oftentimes there is very minimal levels of educational requirements. It's oftentimes somewhere between 8 to 20 hours of education or training that they have as a home health aide.
Great, thanks. All right, I have another clarification question, this time for Dr. Leiter. So this person is asking, in your salary comparisons, are both women and BIPOC individuals making less than their white counterparts, or were you referring to men only?
In the salary comparisons that I presented last, they would match on both gender and race, but that last one was comparing only based on race. However, I will say that in the slides that we can provide after, you'll see a slide that shows kind of the differential, and I think it's 4,000 less compared, 4,000 less for BIPOC staff compared to white staff, all else equal, and 3,000 less for women compared to men, all else equal.
Great. Yeah. Okay, this next question is one, oh, J-Mac, did you want to?
Sorry, can I hop in?
Yeah, go ahead.
All right, I have mostly a ramble that will end with a question. So I'm thinking about the spaces I've worked in perinatal health and this increasing diversity and encouragement of doulas. And I think all three of you touched on the point that it seems a lot of our equity and diversity issues, the solution is let's get Black and brown folks to do the work. But also part of that conversation is this lack of understanding that these jobs have value, and it seems like a real disconnect between let's get Black and brown people in the doors, let's get doulas to fix the maternal health crisis, but let's not reimburse doulas at a rate that is livable. Let's not create an opening that allows more folks to become doulas as their entire professional identity rather than something they do on the side or supplement in some other way. So what does that conversation look like nationally or publicly that we get people to see past the extreme strength that we placed on Black people, especially Black women, right? There is this expectation that these people are really good at what they do, but they can bear it and they don't need to be compensated accordingly. How do we change that narrative? How do we change that deeply rooted social expectation of Black and brown people?
If I can, thank you for that question. It's a great one and one that I couldn't emphasize very much in my own presentation because we have such limited data on kind of like who's in that workforce. And again, I'm glad to see that community health workers are actually being measured in some of our national data sets, but we are seeing that doulas and community health workers who are such a growing group of folks who are caring for our population is that they are mostly women of color who are in those groups. And they also are very low paid in the same way that the support occupational roles that I showed here are today, and they face very many of the same exact challenges. And I think one of the first steps is trying to identify who they are and all their challenges that they're facing to make the story of, hey, we are poorly paying these workers that we're trying to expand. But people are so excited about doulas and community health workers because they're coming from the community, and so that's great. But you're right, we're basically building another cadre of workers who are low paid with very little benefits, and we're saying they can do everything, right? I mean, I hear a lot of conversations that are so excited about the role of community health workers, among which doulas tend to fall in, as kind of the solution for so many problems, in part also because they're not very well regulated at the moment also, so there's a lot of flexibility, and that is a good thing, perhaps, but also that means that they also fly under the radar in a way that then we can't make sure that the workers themselves can be safe in their own jobs. And I think, again, try to figure out at least how to identify and get more voice around who they are as a first starting point in order for us to make the larger kind of argument that we need to protect this workforce also.
So, I'm nodding with you along the way, Jay Meg, and I know part of what underlies your comment is, and also Bianca, you referred to it, right, is the historical devaluation of Black and brown people, of Black and brown women in particular, of any sort of caring profession. And that is what we have struggled with, right, in this construction of race itself, right, in the devaluing of people and their worth and their contributions and their genius and their talent. And yet, this work is core to the strategy of advancing equity. So how do we start to tell that story and also have, because this comes up, and I must say as a Black woman, I struggle with this, but I go into in my equity career journey. What is true is that sometimes, unfortunately, it has to be folk in the other position, the position of power, the white folk, the man, to like actually articulate the value of the Black and brown people, right? And so for that to be heard and to be acknowledged. And I lift it up only because I go into, and you mentioned scope of practice, I go into a number of spaces where we are struggling with really tough health challenges, and there is a lot of boundary setting around scope of practice. Right, and it's about power, and it's about money, and it's about the supply-demand curve that creates different salaries. And so when we think about workforce and what we need in spaces, you mentioned the maternal health space, but in the mental health space and the dental care space, right? Like how do we loosen up? But again, it's threat. How do we loosen up? How do we also value, but how do we also call out what are ways in which we maintain these occupational stratification that results in reduced pay for folk?
So one thing I want to try and figure out how to do is answer your question without like getting in the weeds or the mud, but I can't figure it out. So like join me for a second. During the pandemic, there was all of this money to respond, but it wasn't permanent money, right? It was this emergency response money. So all of this hiring happened. And one of the good things about it is that a lot of states and locals realized, to respond to really racially and ethnically diverse communities, maybe we should hire more folks that are from those communities. And that's right and that's good. But the challenge, of course, is that that money wasn't permanent, so a lot of those positions were contract and temporary, and a lot of those folks were younger, right? Just like we were talking about earlier. And so some of those positions have been carried on, some of those positions have been terminated. And it's one of the reasons that those younger folks, especially Black and brown staff, are much more likely to be not those full-time permanent positions. But to your point and to your question, even if they were better paying jobs, which they aren't necessarily, you have these health educator roles, these CHW roles, and folks who wanted to work for the health department, who still want to work for the health department, are much more likely to be racially and ethnically reflecting their community and to be in non-permanent or non-full-time positions, and now wondering, how do I stay in this job long-term, or what is my trajectory? Commissioner, to your position earlier, I think that is a question that remains, JMAG. And it's something that I think everybody in our field that's doing workforce development is trying to figure out, because fundamentally, unless the feds do something different, we're kind of heading toward this well-known kind of funding cliff in a couple of years, notwithstanding anything that might happen with respect to elections. And that's not something that any state commissioner or local health official can control. It's a really thorny question, but it has real implications for local staff, state staff that want to stay and work and have a career however long in our profession.
Good morning. I think it's still morning.
Yeah, good morning.
I'm Dr. LaTanya Whitley, and actually I got my master's degree in health administration from the School of Public Health, Washington State. And I've been doing this work for 50 years. I'm now 70, and so I think I have a word of wisdom or two. I currently work in homeless space, and I'm doing so because it's probably the most difficult, and it's probably foundational, and we have children, many, many children that are homeless. So thank you for being here. Thank you for the conference, but I want to say, what is a definition of health disparities? Maybe you did that at the very beginning and I was a little late, but it's not a universal definition. And what's happening is everybody makes it fit their own box. And just the advice that I want to give, I've worked at so many places, but I've worked everywhere in health disparities. And I went, as a young person, my intent was to focus, I thought, 50 years ago, that something would change. And I want to say that the change is in each one of us. Wherever your sphere of influence is, that's where you work. And you, Dr. JP, thank you so much for the broader viewpoint, because we need that. But the truth of the matter is, it's in where we put in our vote. We do a lot of talking, we come together, and then we go to the box for voting, and we pull a party lever. We don't even look at who's under that party lever. And there are people there who have the right answer, and many of them are leaving politics like they are a public health for the exact same reason. And that reason is there's no definition for health disparities. I did my doctoral work between Lagos, Nigeria, and Minneapolis, because in 2004, the women of color, BIPOC women, were dying in childbearing. Their mortality rate was higher than the women in a third world country of Lagos, Nigeria. And I wanted to know why. How could that be? And what I discovered in my research, I would tell you, you know, how you get to do your big dissertation and you have a big public audience. Because it was so controversial, they didn't even let me do that. And the reason they didn't is because what the truth was, in Lagos, Nigeria, they had a program called PEPFAR, the President's Health for Women with AIDS, that we did not have in the BIPOC community in America. And the people there were living. And because we had such mistrust for the healthcare providers that cared for us because of all the history of the racial abuses on people of color, they wouldn't take the medicine that was provided for them, and we didn't have a program. And I would like to say, unfortunately, we're dealing with the same thing, Commissioner Brooke, that what happens when people leave medical school, they carry their animosity with them. And when you go to see a doctor, this is what people are telling me, is they don't give you the same kind of care that they do your neighbor. And I can say too, as a professional woman, I'm a nurse practitioner, I have a doctorate degree in nursing practice, I have a master's degree in science and a master's degree in public health, in health administration, and I've worked in all those areas. It's true, it's in our soul individually, and it's in not numbers, and you know, I've got a doctorate degree, I do all the numbering, but what it is, it's at the grassroots level in your own heart. What is it that you will do to change where you live tomorrow? And if everybody did that, there wouldn't be any disparities, not in health, but in anything else. Thank you.
I'm going to say thank you for sharing that wisdom. There is so much that you said in those words, and you know, for me, you know, yeah, people can argue about what disparities are, and they certainly can argue about, you know, why they exist. And for me, disparities are avoidable, right? And that is the key. But people will argue over avoidable, right? And so, but what also you lifted up as you called for our self reflection and our civic engagement is another space that, again, when we talk about what we need to prepare the public health workforce, you know, when I think about things to do in terms of organizational learning, I think about what is our political acumen, because there is, when you walk into the booth, but there is also what we know is important, particularly right now, in terms of community organizing. I don't know, do y'all got a class on community organizing in our School of Public? And I would say that sort of skill set, because again, a skill set is important for public health because it is a highly politicized space. And so we need that more than ever. It is not just about making sure like we do what was regular, like a leadership. And I always say this, yes, Commissioner of Health, but policymakers listen to their constituents, listen to the public, listen to those individual stories, and will recall those in that backroom meeting more than they will recall anything that I ever say, right? And so how do we build that acumen? And then in a space like a state agency, I haven't answered this question, but how do we also fight for ourselves in a way that is advocacy for public health, while that can be challenged as inappropriate lobbying? But I will say that is a skill set. I bring this up and there are a lot of people in public health who have that sort of organizing community work background. But I do wonder when we think about toolkits for the 21st century for public health in a highly politicized environment, is that not one of them? So.
I have so many thoughts, and thank you so much for those wonderful comments. And I was thinking, actually, when I was presenting my own slides, like, did we define health disparities or health equity? I did have a moment of that. And there's certainly academic definitions of, disparities being the kind of differences between communities in terms of their access to care, health outcomes in care. But I think kind of fundamentally what I'm hearing is, this challenge that health disparities has been a conversation we've been having about a long time, about kind of differences in just how we care for people in America. And I really, the part that really resonated in your comments is this feeling of like, you've seen this story before and it feels like there's no action. And I am particularly concerned about this period of time that we just went through with COVID, that did we learn something from it? We put in a lot of money for a very short period of time, and we saw that things worked when we put money and poured money in public health. But somehow we have not embraced that learning to say, well, let's continue funding public health. Putting money in that worked. I hear that specifically in the aging space where I do a lot of work, where there are people who have been advocating for more investments in caring for our older populations. And people are getting tired because, again, COVID was that opportunity that we saw. Nursing homes were where COVID particularly had a huge impact. And so we figured out how to put more resources to shore up and protect our nursing homes. A little probably late, but at least we started putting some money in there. But it still hasn't moved any real needles in the political environment. And I think to some degree, what some of the advocates in that space feel like is they just don't care about older people. They being politicians, they being the population, the people who voted them in to begin with. And I think populations of color, communities of color are feeling that same way. They're saying, hey, this was our moment, George Floyd, that raised a lot of attention in this country. Black Lives Matter, like that raised a lot of attention. And then somehow that moment is now gone, it feels like. It feels very fleeting, and people are feeling very left behind. And sadly, I think the conclusion is that politicians, the general population, just doesn't care about Black and brown people in this country. And I think the fundamental thing is that we have to figure out how we, who care, activate, how we can encourage our communities to be activated. And I think figuring out how to get people the tools to do so is a challenge. I think the question of community organizing, where's that course? I have to admit, I've been doing a lot more work where I'm trying to talk to policymakers, and I realize as a researcher, I really don't have the tools to do that. I talk to policymakers, and I can tell them problems for ages. I can talk about all the problems. And they're like, that's nice. What's the solution? Tell me your solution and how it will move the needle on your problem. And I'm like, oh, okay, well, who did that study? Nobody. So I'm doing back of the envelope calculations to figure this out and whatnot. So where do politicians turn? They turn to social media, or they turn to their friends and family who can tell them a much more compelling story. And I think we are only starting to figure out how can we marry researchers with evidence with the people who are able to tell stories effectively. Like I do try social media. It is a skill. It is a skill. And we, as older generations, and I'm not saying you're old, I'm not saying you're old, I will put myself in, I'm already feeling very out of touch with social media. But I do need to figure out how to partner with younger generations who feel much more comfortable on there and figure out how can we also marry that with the evidence that we have to tell compelling stories.
And I would just add, because your point, I feel like perhaps a generation behind you, like, I feel like I share that sentiment, and I go into rooms where you're like, I've been doing this for 50 years. We having the same conversation. So one of my biggest fears is, shoot, in 10 years, and 20 years, and 50 years, they may have remodeled this place, but are we going to be having the same conversation? And if people are not, like, I am really afraid that that is what is going to happen. And so we cannot continue, right? The old mantra, we cannot continue to do the same things and expect a different outcome. So how are we actually going to free ourselves to do something different and to work differently? Or we are going to be sitting up in this room. So our children and our children's children will be sitting up in this room having the same conversation.
So to your point, Commissioner, and to many of yours, I think one of the ways that we can be and are different now a bit is mixing kind of these ethical arguments, these moral arguments, with a little bit of political science, right? So we see kind of true injustice in workforce, in outcomes, and we've seen things continue. And we see how politicians react to incentives. And I think one of the things that we can and should do is recognize that there are places for moral arguments about why things ought to be different, about fairness. But for those who saw the title of my presentation today, Brownie Points, if you can remember it, but in it was inequality of opportunities. For those of you with a background in political science or ethics, that's another term for that for many is inequity, right? So going from disparities and recognizing the difference between things to inequality, right? A similar term to inequity, right? There's a moral judgment there. But for us to try and move from recognition to doing something about it, right? We did that long ago. Seeing that there's a difference, doing something about that difference, and to your point, how do we keep moving that forward if we're getting a lot of the same outcomes? I think what folks have been doing for the last 20 to 30 years and pairing these moral arguments with the very practical prudential arguments. Today I didn't make ethical arguments to folks. I'm saying, we're seeing turnover in our workforce. And so what I'd say to like you, Commissioner, right, is it costs 100 to 150% of a staff member to replace them, right, which you know very well. And that's a practical argument to leaders, not a moral argument. But we also care about our staff, right? We want them to succeed. I know you do. And I think there's a direct through line to politicians who we want to fund the workforce. We can say, hey, look at these things that happened in COVID. And there are some rooms in which that will play very well and some in which that will play not so well. But what I think you have done very well in your tenure and what your colleagues across the country know is that's the kind of argumentation you have to do to move this forward, is you have to know your audience, and there are some tools you have to have in that tool belt. And that's how I think things go differently in the future. I think that's how you succeed. And you don't have the same conversation in 30 years.
All right, I have a lot of questions, and I think we also have some people in the audience who want to ask questions, so I'm going to keep moving us along. I have topics here on rural health, disabilities. The next question I'm going to bring in from online, because I have a few of them, is around tribal health, and this question is for Commissioner Cunningham. What is your response to what has happened between the Office of American Health and how our communities and employees are enduring harm from the broken relations and respect for tribal sovereignty? And can you talk a little bit about how the state of Minnesota is ensuring that tribal communities are prioritized and how tribal sovereignty is being respected?
Yes, thank you. So I mentioned we have a new Office of American Indian Health. That is such a fantastic development for MDH. And again, came from CDC Health Equity Grant monies that were sort of part of COVID monies. And then the question for us was, how do we institutionalize it and keep the office? Because when you look at Minnesota's health statistics, and probably, you know, health statistics across the nation, right? It is American Indians and African Americans who are at the bottom of statistics consistently. And so when you think about, for me, to answer in terms of sovereignty, and I will say that the Walz administration does take that seriously. We have strong tribal liaisons, and we have welcomed sort of new leadership into both our Office of American Indian Health as well as in our tribal liaison position, which I'm highly excited for. And part of addressing sort of disparities is the how you do it, right? And that looks different for different communities. And for tribal nations, you have to put sovereignty at the front, right? And so, and you have to respect for all peoples what you are hearing from them. And so I am so happy that we have the leaders that we have now in those offices who are not only indigenous themselves and from American Indian communities, but who will help us not only in their work, right, but in the agency work. And so we haven't even gotten to it, and I didn't mention it was probably in one of those pages, right, how siloed we are. But I have encouraged, you know, those team members. I was just on a call with them. I'm like, was it this week, last week? My weeks are long and pass quickly. But I was like, also feel free to like elbow your way into the rooms, because we are very siloed, right? And so when we think about indigenous health inequities, right, it can't simply be the Office of American Indian Health that does that work, but our other divisions, environmental health, infectious disease, you know, like our other divisions also need, and this is the other thing when we think about sort of norms and organization and culture, right, that contribute to structure, but is what is so important is like the humility, right, to listen and to learn. And so, and to let people in to work with you and to partner. And that is what I look forward and have given full permission, right, to help us shape our work in ways that respect sovereignty and that meet the different needs of different people. And also, I will just lift up, because I heard, you know, in your list, there are a lot of different sort of areas when we think about equity, and there are differences and there are ways that we can align for impact. And so to also be conscious of that. So you know, our tribal, you know, it's very interesting to be a representative of the state, right? Mm-hmm. Right, because you know, as a state employee, I carry the history of the state, right? As I move, and that is what we have to, like, we can't leave, that is part of the role of, that I have as commissioner, to understand, to acknowledge that I carry the history and the missteps, you know, and the abuses and the earned distrust of the state. And so to do my diligence to try to not repeat those mistakes, and we're all human, and you know, if the agency makes mistakes, then to acknowledge that and to say we're committed to doing better.
Great, thank you. Let's take an audience question.
Good morning. So I'm an RN care manager working with a healthcare home in the ambulatory setting. I have a very diverse panel of patients who are high complexity, non-compliant, have non-compliant behaviors, or who have mental health barriers or other barriers. And the thing that I find makes the most difference with them, coming from the front line, like real-time data, is the CADDY, ARMS, IHS, mental health caseworkers, all those things. They're the ones making the biggest difference for my patients. And they're, in the long run, going to set them up with the services they need, which will help them to be successful with their health care, which in the long run is going to save this county and the states financially, right? It's all connected. So I would like to know how we can make those roles more visible, more accessible, because they're the ones on the front line changing those people's, helping those people change their lives. And it's hard for me to access them. You know, I had a man who I had to call in as a vulnerable adult twice in a year, what we waited for his CADDY assessment for 9 months, because it took that long. Sorry. So we need those roles because they make the difference. And when we were talking about CHWs and them being the right, them being from the same cultures, yeah, exactly. That's what we're going to see. Is they're going to connect better with someone that is from their history than someone like me who isn't. You know, so that's what we need from the front line. Thank you.
I generally share some general principles that I will just apply here because, again, your story is so powerful. I think one of the challenges, you only told like the snippet of it, right? Like, and this is, from the year in the commissioner seat and to get, because people always say story is powerful, but to actually see how, again, our policymakers hold those stories, but also to recognize two challenges. One, it is hard for when we think about all the constraints, particularly on Bianca, in your category of health support worker, right? Like all of the constraints. You don't make enough money on your job, so maybe you gotta go to the second job, right? Like all of the constraints, right? So, but what happens is in the political space, and this is something that I have shared, is like, it never dawned on me while lobbyists were called lobbyists because they wait in the lobby. But to have the privilege and the pay and the type of the job that you can wait in the lobby all day, and when the hearing gets changed from 8:30 in the morning to 11 o'clock, oh no, oh it got changed to 2, oh no, now it's 6 o'clock, no, now it's tomorrow. To have that time, the luxury of that time to come in to advocate for something. And so this is why I think about organizing, right? Because who has, for those of us who are most impacted, or who the CADDY worker or the ARMS program and making that process work and work efficiently really matters to them. Like often we don't, like again, we're on the front lines trying to put out the fires and make sure people are okay. And so this is why I think about, well, what do we need to build so that we can create space to tell those stories that are impactful, and then also who might have more of that time and space is helping to advocate on our behalf when we're not in the room, which is why like the physician who's me needs to argue for the caseworker and the social worker and the CADDY worker and the armed worker, right?
That's right. Mm-hmm.
So those are the things that I think about a bit in terms of how do we get important workers seen and then paid, right, and supported.
If I can just build on that, and thank you for all the work you're doing, which is very difficult. I think one of the things I find myself where I see what's resonating is saying that these are jobs. I think for some reason we think that healthcare jobs are voluntary positions, that people just want to do them, so therefore we'll just pay them less. There's a lot of that, I think, that kind of permeates underneath some of the conversations, and that's why I think for me it's very important to state that there's 17 million people in this industry of healthcare, partly to articulate that it is a big part of what makes our economy grow, and it is an important segment, not just to keep people healthy so they can stay productive, but as an industry, it is an employer base. It is the employer base of many rural communities in particular. If there's a hospital there, that is like the major employer of that community. That's why you need to support hospitals. However, hospitals are not the only game in town. They cannot operate unless they have people in the community keeping them healthy. You cannot operate without having a nursing home to discharge to, which I think hospitals have certainly been feeling the pain of that because nursing homes don't have enough staff, so they can't even get them to there. Primary care doctors are important referrals to hospitals. So they all work together, and for me, a big part of it is just saying, look at all the people who work in healthcare. There's a lot of people, not just doctors and nurses, though they are certainly important, and they matter. They have lives, and they're going to pick and choose jobs based on what pays them well, what gives them good benefits. But somehow that's lost, and I do think it's important to appeal to the physicians who oftentimes are kind of leading a team or a nurse practitioner or a PA to say, hey, pay attention to the rest of your team because you too are probably suffering because your staff are turning over all the time because they are struggling with life circumstances that everybody else is. And it's interesting to kind of watch that kind of dawn on them, like, oh, yeah, you're right. I am finding myself doing the scheduling when I probably shouldn't be doing that. That's because my MA isn't around, but why is my MA not here? It's because, oh yeah, I guess they did have a childcare responsibility. And you know, it's opening their eyes that people are struggling with things outside of their life, more so than maybe what they're experiencing, but that many physicians or other leaders of healthcare organizations can relate to because they also struggle with them. It's just at a magnitude higher among their support staff. So I think some of it is just becoming aware that people are here for a job to make a difference in the world, and we need to recognize that and treat them like that.
Yeah, I'm not here to like hand out lots of hot takes or anything, but the thing I would like to say is I do wish policymakers sometimes would say less of, you know, X workforce are heroes and more treat the workforce as employees and people and pay them appropriately so that they work there. That would be nice.
All right, we're going to move on to our next audience question.
Hi, I want to say thank you all first for being here. My name is Sydney. I'm a health equity cultural navigator in Hennepin Healthcare, specifically serving the African American community. I'm here with a couple of my colleagues, and there was a discussion that some of us were having actually this week that I wanted to kind of run by you all and get your opinion on, as far as how to keep people encouraged in this field when we're talking about systems and industries and the financial structure of that, and feeling like a lot of those systems benefit off disparities of communities of color to thrive. One of my friends and colleagues was at a panel such as this, and she was talking about a lot of the disparities that communities of color face. And a nurse had said, well, if we bridge all the gaps of disparity gaps, then how do we make money? And so I'm sure a lot of us hear those things in conversation, so I want to figure out what are your thoughts on how to keep people encouraged in this field, especially people like me who are fresh in this industry and want to keep moving forward but feel like they're working against those very constructs as far as, well, this is how we make money if people are sick and things like that, and just thinking forward to how public health and health equity has transitioned in politics and things like that when you're thinking of the business aspect of that. I've been told things, well, you know, you have to figure out, yes, you work with your community, but figure out ways to exploit, and so that you can use it to the benefit to get things for your community, which doesn't necessarily, you know, it doesn't sit right with me. And so I'm looking for encouragement or just other people's perspectives on approaching that.
Well, I give you lots of credit for being out there on the front lines trying to make this work happen during this particularly, I think, challenging and frustrating time.
And I think, on a personal level is to take the small wins that you see every day and say, and take pride in that. That's a first place to start. But granted, how do you make things change at a higher level? It is, I think, an uncomfortable thing in many public health schools, in public health communities, to think about the dollar. I am trained as a health economist within a public health school, and there's like a pretty good-sized cadre of folks like me who are like that. But really, for a long time, health economists or people making conversations around dollars and cents when it comes to health are people who are trained outside of a public health school. And I think we need to figure out how to train more people in the public health field to also talk about dollars and cents. I mean, that's partly why I became a health economist, is because I saw wonderful programs in the field of public health just get decimated because they couldn't quite tell the story around how it made sense, dollars and cents wise. Now, do I do a lot of that work? Not as much as I thought I would, but we need people who can have those important discussions around, I hate to say cost effectiveness, cost benefit of program investment. And it's difficult because we want all programs to exist and to be lifted up. But unfortunately, policymakers are looking to figure out how to prioritize, and they need help in prioritizing what's the best place to put their money. And right now, I think, unfortunately, we don't have enough people who have the skills to make the arguments to help make the business argument around health equity and the value of it. Because there's certainly value there. We're just not making good enough arguments for it. Among which is, going back to kind of people working and what that means, is health equity allows people to be productive members of society, and then that in turn contributes to communities growing and getting better. I mean, that's just one of many, many arguments, but like at a very fundamental level, the argument of improving an economy, a local economy, does resonate a lot for politicians. They are oftentimes thinking about how to improve job opportunities, how to get more money to come back to communities. And you can only do that if you have a productive society that is also healthy, in which they only are healthy because we have public health investments.
And I will say, some of the loudest voices are highly troubling. They can also be highly, powerful and influential and well-positioned. But it's people power out here. That's how we got to keep hope, right? And so I'm like, so Sydney, who'd you say you came with? Y'all raise your hands. All right. Right, you got one person, you got another person. Okay, so it's two of y'all here. Y'all got to find somebody else to come in too, right? And that's what you do in your workspace, right? Because that is going to keep you encouraged, one, when you find your people, right? And then the work is going to be to reach out and grab some other people, and you eventually going to have that conversation with that person and be like, right? But in the meantime, I do believe in people power, and I do believe that, and particularly because you talked about generations, right? And you talk about the under 35, and I don't know when the generation cutoffs, millennials, Gen Z, I don't know, but I do know that the people power, and again, the orientation towards equity that we see in many younger generations, including across both parties, right? That brings me hope, right? And so I believe, yes, these power structures and inequities have been there, and yes, I worry that I'm gonna be sitting here, but when I take it, and 20 years, and my hair will be grayer, right? If I stop rinsing it. But anyway, but like what gives me hope is you coming up to this mic, right? And you bringing your two friends with you, because I believe what is hard is when we feel isolated. That's hard for mental health in general. That's also hard for perseverance in a space around equity. And so, and I will say, in my career, I have felt isolated. And so we have to, and sometimes it's hard to find the energy, because some of the days are hard in equity spaces. And so the other thing I think that people will say, it's now become a refrain, right? But to take care of yourself, right? Like You know, I remember for my, you know, my daughter, you know, she just started school. You know, they have an equity committee. It's at 7 to like 8:30. My heart is there, but I'm like, I can't do it. I do it all day. Right? So also take care of yourself and recognize your limits. But I mean, find your people. Because a critical mass, as it gets bigger and better, it's going to move that needle. And it'll mean that we won't be having this conversation, you know, and the next generation won't be having the same conversation.
Yeah, I would say too, in support of that, I don't think there's anything wrong in feeling like to do equity work that you need to be paid fairly. I think that there has to be a business model that makes sense and is supported sustainably. But if you feel uncomfortable by, you know, wherever you happen to be working at the time, or you hear the term like, yeah, you got to go exploit XYZ, like maybe that's not the right place, depending on what you want to do. There is so much of the work to do that I think we'll be doing it for a long time. And there are plenty of for-profit places that can operate reliably and sustainably, but there's been, you know, evidence that that can be challenging too. And the same, you know, the same's true all over. It's about where you work and what they're doing. So I don't think it's like any one place is right and any one place is wrong. It's about how do you feel about the work you're doing, and do you want to keep doing that, right? I think that's key. If it feels good and you're learning about how the financial structure works and it seems good, great. But don't feel uncomfortable asking about that, learning more about that. You know, money's not a bad thing in the work that you're doing. It's critical. It's critical to understand it.
Maybe if I could just add too, I mean, the role that you're playing is fantastic to hear, and someone has invested in creating that title and role, and some of it is to figure out, well, how can you tell your own story? That this is sounds like a story of success, and that the business you work for decided that this was a worthwhile investment. Why not other people? Why not other communities thinking about that? So I think part of it is making your own business case for your own work and saying, hey, this can be replicated. It's not impossible. This is possible. So, yeah.
All right, I'm going to summarize probably 4 or 5 questions that I have from online into one question, and I'm really interested to hear where you go with this because I think it's incredibly difficult. And the question is,
Thank you, Jeanette.
JP, you're
I'm really
on.
setting you up for success here. The question is, I belong to or I run a small nonprofit or community-based organization, and I want to treat my workers well, and I want to give them good jobs, but I have limited funds. How do I create good jobs for my workers?
I'll try to tackle that. That is a common refrain, but you know, I'll say even the big employers will say, I don't have money either. So I think somehow everybody feels like they don't have money. Not to say that it isn't a real issue. It is a real issue. And I think part of why some of the things I'm trying to get my brain around is trying to figure out how can we leverage resources that already exist so that we don't have to come up with new monies. In part, you know, we talk a lot about increasing pay as increasing wages, and then the conversation kind of dies because there's this feeling that especially small businesses don't know how to negotiate with, or small clinics don't know that they have any power to negotiate with Medicaid or Medicare for better reimbursement, right? So providing benefits is a way to put money back into people's pockets. These are things that they don't have to pay for now out of pocket, and they have now money back in their pocket, like not having to pay for childcare is a great way to do that. But these kinds of subsidies that come about might come from a city, it might come from a state, might come from a county, and that employers can come together and work together, maybe with their Chamber of Commerce, to figure out how to advocate for these county-wide, statewide programs that spreads the cost, that doesn't just benefit them as an employer, but all the employers in their space. And I think that is a kind of political activism that is needed is by our employers to see that they don't have to fight alone. There are business associations that they can kind of work together to figure out how to leverage other state subsidies or county or city subsidies. Like example, for, as I mentioned earlier, you know, public transportation is really important for many of our workers. Well, public subsidies for public transportation can certainly exist in a whole county or in a whole state. It doesn't have to just be the employer themselves figuring it out. Like in King County in Washington State, public transportation is pretty much subsidized for all public employees, including those at the university. So that means I get to take, public transportation, it feels like for free, but I'm paying a very small cost as an employee relative to what I would have to pay otherwise out of pocket. So I would say that's one advice I would provide.
And I guess I would piggyback and just say, Bianca, just to piggyback off of your point in terms of you don't have to do it alone, right, is that all of those things that I listed that we were able to do last session help working people and working families, right? Supporting childcare, child tax credit, universal meals, right? Again, my daughter started kindergarten. Thank you for breakfast, right? And I am not necessarily but I am a working parent who has to get out the door in the morning. Whatever our tax structure is, right, in terms of, tax rebate checks, like those are important. And so to the extent that we can do something on a social policy level, which social policy is health policy, but right, like to support working families, that's going to take a little bit of the load off. When people have a little more resources that are not just associated with the check that comes from their employment, right? But when things are a little more easy, where housing is a bit more affordable, when we talk about homelessness, right? Like, hello, like these are real stresses, and again, I feel like a broken record. But the broken record is, we need new thinking. But the hope is, yes, Barack, yes, we can. Yes, we can. Yeah, and we must. So.
All right, so if you said pay was constrained, I have 4 questions. What are they doing about traditional benefits? What are they doing about non-traditional benefits? What are they doing about their workplace environment? And what are they doing about individual employee development? Traditional benefits and non-traditional benefits, I think, have largely been talked about already, but it's worth saying in the non-traditional benefit space, a lot of those do have direct costs to the employers, but there are some things like, should you think about flex time, remote work, 4-day work weeks? Those are things that folks can do that have been shown to have tremendous quality of life impacts and have huge retention benefits. And that nonprofits especially are really well suited for, that some governments are exploring, but can be harder from a civil service or government perspective. Traditional benefits traditionally have a lot of costs, but as Bianca said really you can look at ways of defraying your costs. For the workplace environment, like this is something that I think we talk about all the time, where when leaders feel really down about pay, that this tends to go out the window for some reason, but is one of the areas where people could have the biggest impact. Because if folks are not engaged with their organization, engaged with their leadership, engaged with their supervisors, that's one of the biggest reasons that they leave. So whatever you can do to improve the workplace environment is worth doing. And then finally, the individual employees' development, whether that's working on literally individual development plans, talking about how are they going to do professional development or paths forward. Obviously, that can be challenging even to do management or leadership training, depending on civil service rules, but there are things you can do for individual employees to show them that they have a path there in a nonprofit space, even if it's a pretty flat organization that is worth doing and is not necessarily costly.
Thank you.
I appreciate Commissioner Cunningham's comment about needing to recruit public health professionals. I do a lot of recruiting and I do a lot of STEM outreach, and I'm often the only public health person at the table, and I'm wondering what recommendations or messaging each of you have around either your respective areas of study or public health in general to make public health a more appealing field to come into.
So I would go back to the values that bring us to the work. That is what keeps people, and particularly in governmental, public health, and that goes back to find your people, right? Like, it is not only a talented, skilled workforce doing critically important work, but to work with people who share those values with you. Again, back to the non-financial, that is a huge payoff. And then the other thing that I will lift up again is, and I would again put this out when we think about pipeline, right, is who do we think about and where do we show up? And really to get, again, self-reflective and critical about, like, how and where are we showing up? Are we doing, I do know that, Masters of, Public Health students have to have, internships, and again, thank you for coming, but also, like, what is the relationship with Minneapolis Public School, with St. Paul Public Schools, with their science teachers, with their after-school program? Can we show up there? I mean, because again, there's a need. Working with kids is fantastic. It means something for their future. It's so many random things that you can experience as a child, and you're like, oh, I never even thought about that. And to see people show up with you, and to think with you about what you see and happening, and to like, help make sense of what people, again, part of my story, and I'm talking to my number, but it's like I was on the school bus as a 6th grader going across Richmond, Virginia, and looking at how the landscape changed. Oh, ain't no grocery store over here, right? Looking at, and you're right, looking at how the resources, it's a lot of liquor stores over here, right? But help, like, think, like, because kids are observant, my 5-year observant, right, and creative, and excited. And so when we think about pipeline, right, like, where are we showing up? So.
I think that's so critical, is telling your own story. And I don't think people realize how much your own voices here, people here who are public health practitioners, how much telling your friends and family about what you do matters in terms of recruitment. I don't know how many of you, but I think certainly some of us up here, found our way to public health very much by accident. There wasn't a public health major when I went to undergrad at Berkeley, though now there is an undergraduate major in public health. But I was on that, I'm going to be a doctor path, and I wasn't doing great in that path. But I wasn't really given a lot of opportunities of like alternative pathways. I happened to sit in an interdisciplinary seminar series, and this gentleman talked about what he did, and I was like, what is this field that you're talking about? That sounds amazing, this idea of preventing things from happening before you ever get to, the healthcare system. Now, he was very kind and opened up his door and was happy to chat with me a little bit more about the field and gave me some good tips that allowed me to then find other people who told me their stories, and that's how I found my way here. But it was people telling me their stories about public health and why they were in it that got me into the field, and I'm sure I'm not alone in that. I'll say another area that I'll say there's actual documented evidence is in the clinical lab world, which is very much an overlap with the public health field. They're struggling with finding enough workers, and they're like, how do we get attention? And we're finding that in surveys that the main way people are finding their way to clinical lab jobs is by word of mouth from friends and family. That's like the #1 way by which people are finding their way there. And that's really great that people are in the field are big advocates for a field and a big recruitment arm. However, that also means that our schools are also not really exposing students to all these different pathways. I mean, I don't know how many children you've heard say, I want to be a public health worker when I grow up. Why not though, right? I mean, but like that's not a common refrain. We're still kind of finding a lot of people say, I want to be a nurse or a doctor or engineer. Good careers too. However, we need to encourage people to also say, be a public health worker. Be proud of that. Have that as a goal. Why not?
People know what epidemiologists are now, so.
No, yeah, that's a start. Yeah.
They do, they've heard of them.
Yeah.
Yeah, I mean, the thing about public health, right, is as a field and not a discipline, we take all comers. You can, say, hey, do you like you want to do clinical work but not have crazy hours, or do you want to do interesting lab work on like crazy infectious diseases, or do you like spreadsheets? I mean, I have younger kids, and they've never seen a newspaper except to put slime on it. But like, if they had ever, you would be able to show on a newspaper how many of these stories are public health stories, right? And the idea that you can impact so many people, so many groups, so much at a time, I think was one of the things that I've always found so compelling when I talk to just folks. That's what's really interesting. But I will say, Bianca, to your point, and Commissioner, to yours, what is really different now versus 5 years ago, people know what public health jobs are, right? They know what an epi is. Never before that, never.
I mean, I'll say TV shows are very effective. I mean, I know it sounds kind of silly, but, forensic science has made significant improvements in terms of their recruitment because of TV shows. And why don't we have a TV show about public health workers? I mean, that's...
Sitting in front of a computer, just typing.
I think there's more drama than
Out
that
in the community.
that we can create.
All right, I want to take time for one last audience question, and then we'll wrap up.
Thank you so much for this wonderful conversation. I had so many questions, but the one I'm going to ask is probably tied to my identity. Thinking about the workforce shortage, there's been a lot of conversation about bringing international medical graduates and international workers into the country to support us in our shortage. So my question to you is thinking about what are the numbers thus far for those who are trained internationally, and then coming to the equity piece, thinking about that as a strategy that helps us in the US, but also it's not helpful for the countries that these people are living from, and thinking about how do we navigate this kind of thorny issues of what's benefiting us, but it's not benefiting the countries where the people are coming from because it's leading to brain drain. So not a short question, sorry, but yeah, just your thoughts on it. Yeah.
We have a few minutes.
Yeah, I can give at least some quick numbers or a sense of kind of the distribution. I mean, immigrants certainly play an important role across our healthcare system, and we do see a number of immigrants in the nursing and physician kind of arenas, as you mentioned, but it's about something like 1 in 5 home health aides are also immigrants. And it's really important to talk about the difference between naturalized citizens versus those who are not currently U.S. citizens, because naturalized citizens often are finding their way to the U.S. very differently than those who are currently non-citizens. And it is those who are non-citizens who oftentimes find themselves more so in those low-paid jobs. One of the challenges is that certainly people, when they come to America, whether it be for job opportunities or for other family purposes, is sometimes translating skills that they had in their other countries. And among the barriers tend to be among language and being able to have enough fluency to get through some of the licensure exams that allow them to get to that next step. And so there are just too few resources out there to kind of invest in those communities to allow them to, folks who come from other countries where English may not be their first language, to pass some of those exams. So that's one of the challenges, is that we have to invest there. But I think to your point about the ethical recruitment part of it, our colleague Polly Pittman at George Washington University spent a lot of time thinking about this, because too often, especially during the pandemic, people have been brought to this country to do work and fill in our gaps, because immigrants are certainly filling in many of our gaps in the health workforce under conditions that are just atrocious. People's visas or passports are taken away until they finish up their contracts. Sometimes the contracts don't quite pan out, and so then they're left without any work. I know Polly's been spending a lot of time trying to advocate and educate policymakers about kind of the situations that are happening. And so we do have to be very careful about building pathways supposedly in the U.S. that are not beneficial to the immigrants, let alone not beneficial back to the communities from which they're coming from. In addition, what does it mean for us to have this global community of workers that are coming to the high-income countries? What does that mean for the communities back where they are and that workforce? And so that's certainly a conversation that's being had, no clear solutions per se on it.
Yes, I have seen those conversations. I don't know the space as well, but raises the thorny sort of ethical, back to the ethical question, the moral question in terms of the global brain drain to benefit certain folk, more privileged countries and often to fill gaps. And, ethically, as I've seen it raised, so what is the obligation then of the country, that is attracting? But there's a lot of, again, it's not a space that I have tracked in terms of the solutions, but I know people have that I've tracked closely in terms of the solutions, but people have asked those sorts of questions like, what is the sort of international aid sort of obligation when you see this pull, right, into your country, leaving the sending country, less well off?
Yeah, I would say in governmental public health, it's not as large of a consideration as in the healthcare space, but we have observed it both on the clinical side and then on the kind of data analytics side. So like the same thing kind of that you see in the tech world, just not as in large proportion, but the question still holds.
All right. In our last couple minutes here, I want to acknowledge that there were a lot of questions that were submitted online that we weren't able to get to, and I want to thank everyone, the online community and all of you here, for your engagement. Topics that came up in the online chat were around the rural healthcare workforce, caring for those with disabilities, which I think is often a very underlooked population when we're talking about health equity, the role of managed care and private equity, which I think is a really, looking at the payer side of things, is a really important part of health equity. Training for healthcare professionals, both for public health professionals, but as well as more clinical workers, and many more. So I encourage you to take a look at the chat and sort of see where that conversation, all these topics could have taken us, I think. It would have been great to have more time. And then if you asked a question and it didn't get answered, let me encourage you to reach out to our speakers, who I think all provided their contact information. I want to thank all of you for attending today. I also want to make sure that we thank the organizing committee that did a fantastic job in bringing together these speakers. The organizing committee for this talk was the Health Disparities Roundtable co-chairs, Dr. J-Mag Carbia, who's in the front row here, and then Drisa Tour. I don't know if I see Drisa. Oh, there he is. So thank you.
Thank you.
And then I also want to thank the Health Equity Work Group's Community Engagement Subcommittee, which was involved in the planning. We also want to give special thanks to Joe and Sue Weisenberger, the UMN School of Public Health Dean's Office, the Office of Diversity, Equity, and Inclusion, the Center for Anti-Racism Research for Health Equity, the Program in Health Disparities Research, and the Center for Leadership, Education, and Maternal and Child Public Health. I want to thank all of you for attending, and then I want to thank our wonderful speakers, Commissioner Cunningham, Dr. Frogner, Dr. Leiter. Thank you so much for your talks and for your engagement in our conversation. And then lastly, I want to remind attendees that we do have an evaluation form. There is a QR code and link. There we go, on the screen. So please fill out the evaluation and provide some feedback on the event. Thank you again.
Thank you.
It's so fun to hear your perspective. I guess I'll let us start off then.
Use and attribute your slides because, the occupational stratification and who we saw impacted both in terms of like essential workers and their health risks, right? But also Yippee! Soon, because this is going to remind us to email. It's so wonderful to see you in this role. Oh, yes. It's a growth experience. So I went to the department as assistant commissioner in March of 22, and I came into this role January 23. But it's growing pain. No. But it's good. But it is a lot of like professional learning for me in this space. In many ways.